So once we're out of that window for JPS, the next procedure that we may consider in the juvenile phase is the triple or double pelvic osteotomy, so TPO or DPO. And this is where essentially we make 2 or 3 cuts to essentially isolate that region of the pelvis that contains the hip joint. We then realign it to immediately achieve better dorsal acetabular coverage, and then subsequently hope that again stops the hip from subluxating. The ideal kind of timing, I think about this procedure more as a stage-dependent procedure versus an age-specific procedure, because what we're looking for is the dog that has dysplasia but yet does not have any bony remodeling. So it still needs to have kind of an acetabulum that fits with that femoral head, but is subluxating, so that then once we do get better dorsal acetabular coverage, that the hip can sort of sit in place and ideally have a little bit of growth potential yet to continue to remodel to essentially having a normal hip conformation following the surgery. So to me, this is actually almost a tougher client to find than the JPS dog, because unfortunately most of the candidates that we see that are a bit too old for JPS, unfortunately they often have either too shallow or blunted of a dorsal acetabular rim, or some remodeling in place, that even if we were to rotate that pelvic segment and better capture the femoral head, those secondary changes will still not allow for good conformation of the hip, and then they'll still subsequently have some pain, discomfort, ongoing osteoarthritis in that area. So how do we screen these cases? This is where I do pretty carefully critique ortolani, because what I'm feeling for is I want a very distinct, crisp reduction feel for my ortolani, meaning that I lift the leg and plunk. It's a really nice solid reduction, because that tells me that I still have a good looking dorsal acetabular rim. If I have a very indistinct kind of soft feel to that reduction, it probably means that there's some blunting of that dorsal acetabular rim, and that may not capture the hip very well. The other thing where the angles come into play are that if I have a very, very steep angle of reduction, chances are, am I going to be able to rotate that pelvis far enough to truly prevent this hip from subluxating and then, getting it to capture well? So if I have a very high angle reduction and subluxation, if I have a very indistinct ortolani, those to me, I can kind of tell right off the bat, just from palpating them, they're probably not going to be good candidates. If I'm not sure, advanced imaging, actually, this is where it can be quite helpful. We used to, before ready access to CT, do what we call a dorsal acetabular rim radiographic view. It's kind of like a skyline view of the hips, where we try to actually visually see what the conformation of the dorsal acetabular rim looks like. Kind of a tricky view that the positioning is shown with the dog that's all taped up and in the awkward position on the table. Nowadays, I find CT is a lot cheaper. It's a lot more readily available. We can do it under sedation at our hospital. I can evaluate both hips and get good idea of true conformation of the hips. So that's my imaging of choice for screening for these candidates. But like I said, overall, I would say these are the toughest candidates to really find.